Good morning, everybody. Is it good afternoon yet? It's still good morning. Good morning, everybody. Welcome to our first plenary session, and I hope that if you attended any of the parallel sessions this morning, that you had a good one. We actually had a fantastic presentations. I very poorly time managed, unfortunately, so we didn't get discussion. So this session, I am going to be really much better at time management. But welcome to all of you. Today's session is titled Power, Policy, and People in Africa, Putting People First. And we're going to have four speakers. I'll introduce each of them as they come up, but Gunasekaran Rengaswamy from UNODC, Maria-Goretti from IDPC, Charity Monareng from TBHIV Care, and Mohamed Motala from NACOSA. So today we're actually this morning we're going to be talking about well, I should say who I am if you haven't, sorry. Look, I'm running around like a crazy woman today. My name is Coleen Daniels. I'm the Deputy Director and Public Health Lead with Harm Reduction International, which is a global civil society organization. I've worked in primarily infectious diseases for 25 years, HIV, tuberculosis, malaria, hepatitis, most of the time with the World Health Organization, UNODC, Stop TB Partnership, and a variety of other NGOs you might have heard of, Treatment Action Group in the US, Health Action International. I also worked a little bit with the Australian government and the Kingdom of Tonga in the South Pacific. But here today, I'm working on drug policy now at Harm Reduction International, and it's just really wonderful to be here and to see so many people. The first time I came to Drug Policy Week was in 2020 when I first started with Harm Reduction International, and it was the best education I could have received for getting me on top of all the issues in terms of drug policy. So in today's session, we are going to talk about the interconnected dynamics of drug policy, the influence of power, and the ongoing challenges in Africa. Today we will look at the global context, current policies, and real-world cases. And so we're hoping that this session will enable us to have a little bit more of a nuanced understanding of how these elements all come together and shape the realities on the ground. So to give you a little bit of background about the war on drugs and why we're sitting here today talking about drug policy, it actually started, the whole strategy on the war on drugs started when President Nixon began his administration in the United States in the 1970s. And he had two major problems when he entered office. He had the anti-war left, those who were against the Vietnam War, and he had the Black civil rights movement, both happening at the same time. And so and he couldn't make being anti-war illegal, and he couldn't make being Black illegal, though they tried for many years. And so instead what they decided to do, and it was a whole strategy, they sat down and they wrote the strategy, and they decided to associate cannabis with the anti-war left. And they decided to associate cocaine and heroin with African Americans. And in that way, they were able to disrupt the communities. They were able to imprison their leaders. It enabled them to kill the leaders and basically kill the two movements. And that's how the war on drugs developed around in the United States. And then together with Western Europe, they started exporting this strategy to the rest of the world, which is why people who use drugs continue to suffer at the hands of law enforcement, at the hands of our governments today. Because we very blindly took on these policies as if they were our own, as if they were something that we needed to fight. But we didn't need to fight the anti-war left, and we didn't need to stop the Black civil rights movement. So the question here that we're all trying to answer is, well, why the hell do we still have a war on drugs in South Africa, in Botswana, in Ghana, in Mauritius, in Morocco, in Africa? And it's because we allowed colonial institutions to remain, and we allowed colonial mindsets to remain. And so here in South Africa, when we changed our constitution, it's now one of the most progressive in the world. When we changed our constitution, we didn't necessarily change our colonial mindset. So we adopted a lot of policies, a lot of laws that actually don't work for us, shouldn't work for us because they work in an American context or they work in a British context, but they certainly don't work in an African context. And so today, and we know that this happened in the United States because John Ehrlichman, who was a former assistant in the Nixon administration, in 1994, he said, "We knew we couldn't make it illegal, but we needed to arrest their leaders, we needed to raid their homes, break up their meetings, and vilify them night after night on the evening news," which is why today we associate people who use drugs as being bad people, right? And that's something that's become ingrained in our minds. Even though, and Gunnar will give you some of the statistics next, but we know so many people around the world use drugs. We know only a small fraction of them actually have a substance use disorder. But we know that many, many more people, they just enjoy drugs. Why can't we let them? We all eat sugar. We enjoy it. I mean, we get fat, but we enjoy it, you know? So here's the thing. What about bodily autonomy? Where does that fit into this power play and into these politics? Because I haven't heard any of that come up when we talk about drug policy and reforms. So we need to be able to move this forward. We need to be able to change our current global policy structure because currently it is based on oppression, it is based on subjugation, and it is based on aggression. And in fact, in many countries, anti-blackness has been the result. So it's anti-black, brown, and indigenous people. So any of us who don't look like President Nixon become parts of the targets of this system. And it's seeped into every aspect of our lives, into our laws, into our policies, our structures, and our belief systems, because now we believe that people who use drugs are bad. And so the use of drug control by states in Europe and America to advance and sustain the systemic exploitation of people, land, and resources, and the racialized hierarchies, which were established under colonial control, continue to dominate today. We just call it other things. It's called a government department sometimes. And yet, in the 19th century, psychoactive substances were among the commodities that colonial governments used. This was how the United Kingdom became rich. They actually went to war with China so they could control the opium trade. And yet 66 years later, the Single Convention on Narcotic Drugs of 1961 was adopted. And so in less than a century, drugs had gone from an essential part of European colonial trade to, in the words of the Single Convention, a serious evil that leads to personal degradation and social disruption. Now, I've worked in the United Nations for many, many years, and Gunnar also has. There are no other treaties or conventions that have a moral application. We talk about the right to health. We talk about the human rights. But in the Single Convention on Drugs, we talk about a serious evil. We talk about it's a moral perspective. It's a moral judgment that has been allowed to penetrate all our systems. So today we are going to hear from and I'm going to get this correct, I promise. You know, with living in so many different countries and you get this weird, messed up accent, the pronunciation also becomes really challenging. But our first speaker is going to be Gunasekaran Rengaswamy. He is the Regional Program Officer for HIV/AIDS Prevention and Care in Southern Africa, based in Pretoria in the UNODC office. His focus is on programs for people who use or inject drugs and those in prisons. With a Commonwealth Fellowship and over 3 decades of experience, he has worked with the United Nations and various not-for-profit organizations. He has led and managed substantial projects across diverse cultures in South Asia, West Africa, and the Middle East. As the health program lead, Guna serves as the focal point for prison programs in the Southern Africa region. His previous roles included serving as regional advisor for HIV and AIDS in West Africa and South Asia, based in Nigeria and Delhi. Please welcome Gunnar. And I am going to try to do my best.
So you'll say when there is 5 minutes, huh?
I'll let you know if I...
Okay. Where is Good morning, everyone. So thank you so much, first of all, for inviting me to be in this panel. And thanks for giving a warning also, Coleen, that you will strictly stick to time. But let me give a little note from my side that this is a huge presentation, but I'll try my best to cut it down. We are talking about the World Drug Report, and it has 6 volumes. And it's too difficult to condense it. I have tried my best to bring it to, some form, but I will focus on the important steps. So World Drug Report 2023 is usually World Drug Reports are published on the June 26th. This year's World Drug Day theme was People First, Stop Stigma and Discrimination and Strengthen Prevention. So let me begin by saying that inequalities are increasing health problems associated with drug use. Drug use continues to be high worldwide. 1 in every 17 people worldwide had used drug in 2021, 23% more than a decade earlier. The estimated number of users grew from 240 million in 2011 to 296 million in 2021. This is a 23% increase. Cannabis continues to be the most used drug with an estimated 219 million users. In 2021, 36 million people had used amphetamines, and 22 million had used cocaine, and 20 million had used ecstasy type of substances. The proportion of female drug users is higher in the case of amphetamine type stimulants. Opioids continue to be the group of substances with the highest contribution to severe drug-related harm, including fatal overdoses. An estimated 60 million people engaged in non-medical opioid use in 2021, 31.5 million of whom used opiates, mainly heroin. Some technological challenges. Okay. Like I said before, opioids continue to be the main drug that impacts the global burden of disease, where cannabis is reported by large the share of the drug use in most concerned in the disorders. So if you look at the bars at the left-hand side, and you can see the green ones are cannabis. You can see it very much there in the region in Africa. And you can also see significantly in East Africa, opioids is there. And in Southern Africa, also opioids is there, also in North Africa. And Western Central Africa, the bar is growing. So you also can see this, new psychotic substances, which is also prevalent in Africa region. The new data that has put the estimate of people who inject drugs in 2021 at 13.2 million people. They were using drugs in 2021. This estimate is 18% higher than in 2020. So the risk of acquiring HIV is 35 times higher for those who inject drugs than those who do not. The joint UNODC, WHO, UNAIDS, and the World Bank global estimate for people who inject drugs living with HIV is nearly 12%. So 1.6 million, that is 1 in 8 people injecting drugs is living with HIV. Injecting drug use is one of the important factors for driving the global epidemic of hepatitis C, with the WHO estimating 23% of the new hepatitis C infections are attributable to unsafe injecting. In the case of drugs, there are more men than women injecting drugs. Men are 5 more times likely than women to inject drugs. This is based on a limited data that has been obtained from 18 countries, whereas women who inject drugs are 1.2 times more likely than men to be living with HIV. So yesterday our Honorable former President also mentioned about this. There is large inequalities that remain with regard to pharmaceutical opioids for medical consumption. So it is there is overall there is a 40-fold difference in the availability of opioids per capita for pain management and palliative care between high income and low and middle income countries. Some 86% of the world's population live without adequate access to pharmaceutical opioids for pain relief and care. Some progress has been made in the recent years with regard to making available methadone and buprenorphine over the last 2 decades. They are not only used as analgesics, but also used as opioid agonist medication. Despite these positive developments, there remains an extremely wide diversity in the availability of opioids for medical purposes. When it comes to the barriers for treatment to women, an estimated 39.5 million people worldwide were suffering from drug use disorders in 2021. Only 1 in 5 people with the drug use disorders receive drug treatment. This is really concerning. Barriers in accessing treatment are multiple, but women are most affected. Almost 1 in 2 users of amphetamine type stimulants is a woman. But only 1 in 4 people in treatment is a woman. In addition to the family expectations and responsibilities that women face, women may experience further barriers in accessing treatment. And women who use drugs also may be part of certain groups who are survivors of gender-based violence or sex workers or people in prisons or ethnic minorities. Young people, obviously, needless to say, Africa has a very young population. Out of the 1.3 billion population, around 50% are less than 20 years old. In 2021, 5.3% of 15 to 16-year-olds worldwide, 13.5 million had used cannabis. Young people. In most regions, the proportion of the adolescents using the drug is higher than in the general population. The use of new psychotic substances, psychoactive substances, is generally higher among school students than among the general population. Like we all know, sometimes there is not enough data that is available for us to really clearly share this. In Africa, 70% of those in treatment are under the age of 35. This is just a map to show the trafficking routes. I'm not going to too much talk about it, but I thought it's worth just putting it on the screen for you to have a look at. The big arrows really indicate the volume flow of heroin from one region to the other. You can also look at Africa. It also is heroin comes into Southern Africa region through the southern route. And when it comes to cocaine and cannabis trafficking routes, you can also see, lots traversing through the Africa region. And many a times, drugs are also spilled over or they become destination points and they are also sold and consumed. So the report also shares that there is availability of cocaine in the Africa region. The another thing that I would like to mention is the world is currently experiencing prolonged surge in both supply and demand of cocaine. There is a marked increase from 2020. So I looks like I have only 5 minutes. I may have to rush. I have a couple of more slides. I'll try my best. But I don't want to miss out. These are important points. Okay. The point is cocaine users also have grown significantly, and it has also found markets in Africa. And if you look at these dots, you can clearly identify that cocaine is also found a way to Africa, and it is also available. And methamphetamine continues to expand beyond the traditional markets. And earlier it used to be concentrated in East and Southeast Asia, North America. Now we can find the manufacture of methamphetamine is not only restricted to those established markets, but with the clandestine labs, methamphetamine is also available in Africa. This needless to talk about this, the relationship that exists between drugs and conflict. Places where there is conflict, like in the Sahel region and the weak rule of law, the illicit economics have continued to flourish and use that money for various purposes. So synthetic drugs are shifting drug markets and supply chains. A growing number of laboratories have been detected also in Africa. Synthetic drugs offer criminals several advantages, namely lower operational costs, fewer production impediments, and reduced risks of detection and prosecution because they can be produced closer to the destination. And consumers are facing growing challenges from synthetic drugs owing to unknown pharmacology and harms of the drugs. Lack of pharmacological treatments for these new psychotic substances, therapies, is a problem. The other opioid crisis is the non-medical use of tramadol. This also is continuing to affect countries in parts of Africa and Asia. There is significant individual phenytoin and tramadol seizures in the last reporting cycle. It's also, like I mentioned before, in the Sahel region, you can see it much more. I'm given a warning for 2 minutes, so let me try to capture whatever I can. The other thing is, I just want to mention, this is also important to mention, ketamine could become a mainstream drug in some population groups. It is also, in North Africa. This is something that I would like to also emphasize is that number of new psychotic substances on the market has increased in 2021 after several years of stabilization. Of the 618 substances reported to be on the global market in 2021, 87 were newly identified. The cumulative number of psychotic substances identified over the last 15 years is 1,165, and currently it is 1,184 substances in 2022. Needless to say, I think this sums up a lot of things that I said before. New drug combinations and the ease of manufacturing and is a growing challenge for monitoring and treating drug use. And we have, UNGA, NAOPE, and all that also exists here in South Africa. And increased digital connectivity has made things much more easier for operation of darknet marketplaces catering to illicit trade in drugs through social media platforms and encrypted communication applications. And one another thing is that among the drugs that are bought through the internet, new psychotic substances appear to be the accessed most on specialized internet shops and on the dark web. It is important to balance access and safety with internally controlled drugs. This is the whole point about access and prevention of diversion and non-medical use of controlled substances and drugs. So this is my last slide. So I tried to rush as much as possible. I swallowed quite a lot. I'm sorry about that. But I'll share this presentation considering the time. So after releasing the report, our executive director said this: we are witnessing a continued rise in the number of people suffering from drug use disorders worldwide, while treatment is failing to reach all of those who need it. We know the numbers of people who are increasingly using drugs and the treatment gap that exists. Meanwhile, we need to step up responses against drug trafficking rings that are exploiting conflicts and global crises to expand illicit drug cultivation and production, especially of the synthetic drugs, fueling illicit markets and causing greater harm to people and communities. So thank you very, very much.
Thank you so much, Gunnar. And yes, I know I'm sorry about the time. It would be great if we could have a lot longer for all of these because there's so much amazing data out there. And we'll take questions at the end of all the presentations. Next, we have Maria-Goretti, who is a prominent lawyer in Ghana and is also the African consultant for the International Drug Policy Consortium, where she oversees the African regional work and offers support to IDPC network members. Specializing in human rights and drug policy reform, Maria has actively engaged in high-level advocacy on drug law reforms and harm reduction implementation, both locally and internationally. Her passion for these subjects extends to her role as an author with several articles and research publications in the International Journal of Drug Policy, focusing on drug use and harm reduction. Her recent publication explores how drug control governance in Africa impedes public health with a focus on tramadol and other controlled substances. Her research interests span law and development in Africa, women's health, drug policy, and human rights. And for many years, she has enriched the field through teaching and facilitating training on drug policy. Please welcome Maria.
Can have the slide on. Okay, so good morning once again, and thank you for giving me the opportunity to be part of this panel. So we've heard the data, we've heard about the global picture, the statistics and all that. So basically, I'm going to look at how is Africa faring? How are we, how are we doing? Are we doing good, or we need to step up in terms of our game? Yeah, so as mentioned, I work with the International Drug Policy Consortium, a global network of civil society that advocates for drug policy grounded on health, human rights, development, and social justice. So if you look at the nature of drug policies generally across the continent, it's basically rooted in the prohibitionist perspective of interpretation of the international conventions. We basically, especially in terms of our governments, the main focus is more on criminalizing people, arresting people, seizures, the amount of seizures we are making across the continent, the amount of people we are arresting, the total, these are the things that basically many governments across the continent are doing. Now, if we look at our performance, I will say that it isn't too bad, but of course, we need to improve upon what we are doing. If you look at the Global Drug Policy Index that was launched in 2021, it was done for, I think, about 30 countries. We had about 7 countries in Africa that were also assessed. We had South Africa, Mozambique, Ghana, Senegal, Uganda, and some few other African countries. And we did not really do that well. If you look at the statistics, Africa wasn't really doing well. And that is not surprising because we know the kind of focus in terms of our government perspective in terms of drug policy. And if you also look at some countries currently, there are still some countries that still have the death penalty in their laws, which are still being, probably might be dormant, but of course we need to do something around that. Now, if you look at these approaches, we've heard Guna this morning, especially in terms of the health implications of the over-criminalization of persons who use drugs, especially focusing more on supply reduction strategies other than putting in resources to address some of the unintended consequences of the focus on the war on drugs, sort of. We've seen a lot of human rights violations where people are arbitrarily arrested. We have heard in other countries where people are even executed for drug offenses. We've also seen instances where our prisons are overpopulated as a result of these petty non-violent offenses. And of course, 2021, we did some kind of like a rapid assessment of prison populations of minor offenses that are packed in our prisons. We looked at South Africa, we looked at Ghana, we looked at Nigeria, and it will amaze you the number of persons who are serving jail terms for just minor offenses like a wrap of cannabis, small quantities of cocaine, small quantities of heroin. And it's worrying that we are pushing a lot of resources into these areas other than investing these resources in areas that can improve the lives of people whom we are, who are citizens, who are brothers and sisters. So there's need for us to begin to rethink our drug policies. We need to think outside the box and see what we can do around that to improve upon our drug policies. Also, in terms of availability of essential medicines, yesterday we heard about how, I think, close to about 0.5 metric tons in terms of availability, how essential medicines availability in terms of the continent consumption. That is not to say that we are not really consuming these, or these substances are not needed for pain management. They are needed, but of course, if you look at most of our laws, they place a lot of impediment in access of some of these substances. And of course, if you look at the structures that are even put in place to access these essential medicines, it's so the bureaucratic process in terms of how to even get these substances available for medical use are quite cumbersome, and many countries will not do that. I remember 2018, we were looking at access to pain management, especially in respect of tramadol use within West Africa and selected countries. And you visit big-time hospitals, and they'll tell you that they don't even have morphine for cancer patients. And this is as a result of some of the impediments we have put in place in terms of our laws that are denying people of these essential medicines. And I always say that these denials are gross violations of human rights of these people, and we need to do something around that as a continent. Sorry, I'm so sorry. It looks like I messed up with the slide changer. Now, so if you look at Africa, are we really seeing a shift in terms of moving towards more humane drug policies, putting people at the center of our policies, putting communities at the center of our policies? I would say that, of course, yes, we are seeing a change, despite the fact that it's a little bit slow, but we need to at least take some steps to make sure that that happens as a continent. And of course, we need to be looking at a comprehensive approach to this drug policy. We need to make sure that it touches on all areas. Of course, many of our governments, the focus is more on the security aspect of things, and of course, resources are being channeled to that direction. And that's not to say that we shouldn't focus on the security aspect, but of course, other areas need some improvement, and we need to make sure that we do that. And some countries are now beginning to also appreciate the human rights conversation of drugs, and which is good, because we have seen over time countries that are now even considering the conversation of reviewing their laws. Some have actually taken steps to do that. We have seen countries like Liberia, we have seen countries like Ghana that have taken steps to actually sit down and look at the laws. They might not be perfect, but of course, there has been that appetite in terms of making sure that we review our laws to do that. And then also, we have seen the desire and the appetite within the African Union itself in terms of looking at how they can encourage member states themselves to ensure that these policies and laws within the national level reflect a comprehensive nature. The action plan in terms of the 2019-2023 action plan of the African Union actually emphasized on the need for many member states to focus on making sure that there is access to what? Harm reduction, there is a removal of criminal sanctions in terms of persons, alternatives to imprisonment for persons who use drugs, and also ensuring that there is access to essential medicine for pain management. And I think we are doing well. We are not doing too bad. The fact that the desire and the appetite is there to have this conversation is something good that we need to really continue to do. We have also seen in terms of countries that are now beginning to focus more on harm reduction. That is, of course, we've seen quite a number in terms of, if you look at the Global State of Harm Reduction, the 2022 report, many other countries are beginning to implement harm reduction, which is good, but I have always said that in as much as we appreciate the services that we are providing for these people, if we do not do something about the legal environment, the criminal environment that is still created for these people, it is becoming difficult for many of them to come out to access these services. So as much as we are providing services, let's also look at the laws themselves that place an impediment in accessing these services by these people. So we need to also review the laws. We need to decriminalize drugs and take away the stigma and the discrimination that these people go through to be able to access these services. Now, of course, I've mentioned a few countries. We have seen Ghana, where they have introduced fines other than custodial sentences for persons who use drugs. Ghana has started in terms of putting in place some measures to start harm reduction in November in terms of a pilot study. We have also seen the law that is passed on cannabis in terms of regulating cannabis production for medical and industrial purpose. We have also seen Morocco that has also done a lot of things in terms of cannabis and then also harm reduction policies. South Africa in 2018, as we all know, the Constitutional Court did make some pronouncements. And I am looking forward to this, a day when we'll really have this, a policy that really addresses the key issues on the ground, because we talked about the fact that it is decriminalized for personal use within private space. What happens to persons who are supplying? What happens to people who are selling? Or what happens to persons who are also distributing as a social way of generating resources to support even their own drug use? Because if you look at the law, it still criminalizes these people, and the law is still harsh on them. We've seen Senegal, in terms of harm reduction, there has been progress in terms of making services available to these people. Now, in terms of priorities, where should we focus as a continent? What should we be doing as a continent? And I believe that the implementation and awareness of the action plan of the African Union itself, in terms of the common position, as well as the international guidelines, are basic. They are the basis on, from which we can actually draw inspirations to work around our laws and improve upon them. We also need to scale up in terms of harm reduction, as I mentioned much earlier on, in terms of looking at domestic funding, because if you look at harm reduction, it is donor-driven. And how long can we be relying on donor support for harm reduction? Does it mean that when this is withdrawn, everything comes to zero? We need to begin to look at it from the national level perspective. How do we get our governments to commit to putting in resources to ensure that there is continuation of harm reduction at the national level. And as I said, decriminalization is something we need to consider seriously as a continent, because so long as people are criminalized, they are not free to be able to access what you have put in place to support their lives. And we also need to engage with our governments. Our governments must begin to be participating in most of the conversations around drugs. Open, honest debates must take place in our at our national level and at the regional level. And we need to get them to be engaging also at the global level, because sometimes you go to the global space and our governments are not really telling us what is happening. They are not saying much. And we need to hear their voices and what the international commitments they have committed themselves to. We need to hold them accountable to that. And we need to make sure that civil society is also ensuring that there is that audit in terms of what is happening at the national level against the international commitments that we have at that space. So of course, in terms of the conclusions, I will say that if you look at the drug policy generally across the continent, there is a wide disparity in terms of what policies are being put in place, what is implemented. There's so much vast disparity in terms of what is happening on the ground. And then also, disproportionately, the laws are affecting very marginalized, poor communities. And that is something we need to look at seriously. And we also need to build bridges and engage states across Africa to make sure that there's further progress in terms of the work. We need to divert money spent on policing to ensure that that money is put into harm reduction and other strategies that we need to do. And of course, develop a constructive debate that will lead to more humane and evidence-based drug policies. And as I said earlier, we need to ensure that there is that civil society audit of national governments against the international commitments that we make. We go out there, we commit ourselves to certain things, certain resolutions, we come back at the national level, nothing is done. And I challenge our civil society in this room that we need to begin to hold our governments accountable. We need to do civil society audits around that. Thank you very much. I'll sit here, and then when there are questions, we pick up.
Thank you so much, Maria, with the very inspiring call to action. And you did it. You had time to spare, so even better. Our next speaker is Charity Monareng, and she is the Parliamentary and Policy Research Officer with TBHIV Care in South Africa, where she passionately advocates for drug policy reform at national, regional, and international levels. She also serves as the Executive Director of Students for Sensible Drug Policy International, leading the largest grassroots youth movement in the field of drug policy. Her influence extends to board roles within the South African Network of People Who Use Drugs, SAMPUD, Digital Girl Africa, and as a chairperson of the Stand Action Board. Currently, Charity is pursuing her PhD in the Department of Public Law at the University of Cape Town, because she doesn't want to be an overachiever or anything, reflecting her deep commitment to law and public policy. Please welcome Charity.
Thank you so much, Coleen. It's always strange for me hearing my bio because it makes me sound so amazing. But yeah, so thank you once again for this opportunity. And I'm going to be speaking on the role of power in drug policy. Okay. So I think we can all agree that the drug prohibition has failed. But I don't think we really realize the kind of power that it has allowed on certain institutions and organizations to control society. And I think that's an element that we really need to start looking at, because as much as we can talk about how police are arresting people and how different governments really influence how South Africa, for example, guides or governs its society, we are not necessarily aware of the kind of power that drug prohibition has given to institutions. And so drug prohibition has given power of the police not only to arrest people, but it has given them the opportunity or the tools to really oppress marginalized communities. And we see this a lot around arrests of people who use drugs. And this was mentioned in the previous session about how police's performance is really guided by the amount of arrests that they do. And it's unfortunate that we're basically counting the performance of police by the number of arrests that they're making, instead of really looking at how society is really changing and maybe how safe society is when it comes to police's performance. So police as well are used as tools within the drug economy. So drug prohibition has given the police the power to oppress humans, but it has also given power to the illicit market. And this is an element that we tend to forget. And unfortunately, police officers are not paid enough, and this has led to corruption, which has led to police officers really becoming pawns and tools of drug cartels. So another element is the exertion of power by foreign states. We talk a lot about the US, and we don't necessarily have clear examples about the impact that they actually have on compromising the sovereignty of states. And I'm just going to give you tell you a little story about the influence of the US on an incident that happened with the African Union. So I was invited to speak by the African Union at a meeting, and I was going to speak on harm reduction. And the program was set, and unfortunately, when it came to approving the program, I was clearly asked to not be included in the program. So the reason for this was because I seemed to have a very strong harm reduction perspective, and so my section or opportunity to speak was completely scrapped out. We also see how the United States, because of funding UN agencies and the amount of funding that they actually put into the harm reduction strategy, has really imposed this drug prohibition perspective in countries. And so countries are forced to implement not necessarily harm reduction strategies, but drug prohibitionist approaches to addressing drug use, which has, as Coleen mentioned, exacerbated or continued the legacy of colonialism and apartheid in South Africa. The compromised power that drug prohibition has afforded is that it has obviously compromised the power of police, not only to be able to get information for people who use drugs, it has also compromised the police's ability to correctly gather intelligence, and also leaves police vulnerable to being exploited by drug cartels. As I mentioned, corruption and the low salaries of law enforcement officers has resulted in them being compromised and exploited by drug cartels, and they're being forced to execute the oppositions because of the influence of the drug cartels. However, we are seeing policy shifts, and this has really been key in giving power not only to civil society organizations, but communities of people who use drugs. And decriminalization conversations, not only being at the international level, has also resulted in the shifting of power, where people who use drugs and community or civil society organizations are really being invited to tables to discuss policy shifts and policy decision makings, which basically encapsulates our theme of putting people first and hearing and learning about experiences from people who use drugs, and not necessarily getting the top-down approach and rather a bottom-up approach where we are listening to what people need and not telling people what they need. There's also been activities where police officers are being sensitized. I don't want to sound as an advocate for law enforcement. However, we are seeing that law enforcement officers are starting to realize the failure of the approaches in arresting people who use drugs, because they're talking about this vicious cycle where they continue arresting the same people. And so efforts are being made where people who use drugs are actually being invited to train the police officers on how to treat key populations, so sex workers, LGBTIQ+ communities, and people who use drugs. And And even though we are slowly seeing shifts, it's better to change one life than to not change anything at all. And so these efforts are really seeing some progress in how we can better police drugs. And so in conclusion, criminalization has compromised the power of police and state sovereignty. Police are an extension of political ideologies, and if you want to understand how political issues are, you look at the police. And so, however, when it comes to translating policy changes within the governments, we don't necessarily see it being translated to law enforcement officers. So national policies can sound great. However, when you go and speak to law enforcement officers, they don't know about the policy changes. We still have law enforcement officers saying that cannabis is legalized, and we're not only seeing it in law enforcement officers, but also civil society organizations that think or believe that cannabis is actually legalized, but that is not the case. And so we need to start educating people on the correct terms and even translating policies in a simpler form, not only to key institutions, but also to people on the ground. And decriminalization can see shifts in the distribution of power, allowing for more bottom-up approaches to policy. In essence, we need to start putting people first. Thank you.
Thank you so much, Charity. And I think it'll be interesting for our discussion later as well to talk about actually the militarization of our police forces, in particular by technical assistance that comes from the United States, from Russia, from China, and the European Union. So I'd be interested to hear more from the audience as well about that. Our final speaker is Mohamed Motala, the Executive Director at NACOSA. He has a profound background shaped by his upbringing in poverty-stricken rural KwaZulu-Natal. With degrees in geography and town and regional planning, his career has been driven by a passion for social justice. He founded Tekano Health Equity South Africa, led the Community Agency for Social Inquiry in Johannesburg, and has 15 years of experience in HIV and health work. Mohamed's leadership at NACOSA emphasizes community engagement and improving health equity in South Africa. Committed to making a tangible difference in the lives of those in need, he focuses on resilience, service delivery, and collaboration with local community-based organizations. His vision aligns with NACOSA's goals to inform better outcomes in health improvement and address the challenges of economic, racial, and gender disparities. Please welcome Mohamed.
So, thank you for giving me this opportunity to speak with you today, and the excellent panel members who outlined the issues and sort of gave a background. What I want to talk today is more about policy, how policy is made, and policy influence, and where policy needs to change, or how it can change. Putting people first is the title of the conference, and I'll stick to that. So the background information, or the things I'm saying, the information comes from NACOSA's programs, and I'll explain some of that later. CASE, the Community Agency for Social Inquiry, was a research NGO that did extensive research throughout the transition in South Africa, but this was applied research in poorer communities. We sought to inform public policy from the perspective of poorer individuals and poorer households, and did this through large-scale national surveys and all other forms of research as well. The policy work that informed, and the policy work that I've been engaged in, essentially focused deeply on the conditions under which poorer South Africans live. The social, and specifically coming to this, it gave me an understanding of the screen's gone blank. Sorry. The socioeconomic conditions of the P-word community. So understanding the conditions under which the P-word community lives, who they are, where they come from, what shapes their lives, what shapes the drivers in their lives, and how that can influence policy is where I'm coming from. And lastly, the historical nature of policy evolution in South Africa, because as the speakers have pointed out, the kinds of policies we have, nobody sort of woke up one morning and said, I think this is the way we should go. These policies have evolved, and there were major drivers. I think one of the drivers, the economic system that drives the kind of policies that we have, who's getting rich by the kind of policies we have, the pharmaceutical industries, COVID, and the vaccine, and the money that was made out of the vaccines, and the extent to which vaccines were even made in Africa, but not available to Africans. All of that insight as to who's making money, what kind of economic system we're having, and how is that impacting on the problems that we're having is also an added sort of lens, apart from the racial aspects that were covered by the speakers. So the history for me of the economic system and the drivers of that. Briefly, these are our programs, and essentially our programs are driven by HIV and AIDS. For our harm reduction programs are in KZN, in the Western Cape Province, and in Gauteng. So the basic outline of what I want to talk about is how colonialism, and in the South African context, apartheid, continues to define the legislative and policy frameworks within which dependency on harmful drugs, on drug use, is managed by governments. And I want to suggest areas and make some suggestions on how the policy process can be improved. In the opening plenary, some of the things I said was the role of civil society, the role of NGOs, how in this country and across the world we've seen less and less involvement of organizations that are actually working amongst poorer people, amongst affected communities in forming policy. We handed a lot of the power over to our governments, our democratic governments, especially when the change came in South Africa, and it was very stark. Previously, NGOs and social movements always had policy and research going as part of their work, but today it's hard to find that kind of resource. Where I'm going to, sorry for the spelling error there, it's the criminalization of marginalized groups. And when you look at the P-word community, when you look at sex workers, when you look at shack dwellers and informal settlements, and when you look at street traders, all these communities are criminalized. So, you know the saying, if you're a black man, you're born as a criminal. Or if you're poor, you are a criminal. But in these communities, in the work that I've been doing over the years, supporting street traders, and we know how essential they were. When there was a hard lockdown during COVID and there were no street traders, the food chains in poorer communities collapsed. That led to looting and wide-scale rioting. There was no food to be found. Street traders were so integral. Yet if you go around Cape Town, especially in the City Bowl, no street traders, except for the posh ones that are selling things to tourists. But actually people trying to make a life out of it, it's made illegal. Shack dwellers and informal settlements, they're huge shacklands in Cape Town. You see them as soon as you land at the airport. And the extent to which people who are trying to build homes for themselves, the routine demolition of shack dwellers, and their lives are criminalized. Sex workers, I think other colleagues who were here and Sisonke and organizations like that can speak much more eloquently about that and the extent to which sex work is criminalized. And I won't talk about the P-word community because you are experts in that field. So all the above communities are constantly and routinely coming into conflict with the law. If I wanted to trace the evolution of policy and legislation, the criminalization of poorer black youth in the USA and the Black Lives Matter movement, the speaker spoke about that, Coleen, when you started. And essentially, all the research and the writings of people like Angela Davis talk about how slavery has essentially morphed into the prison system in America. And there's the abolitionist movement, which says we actually need to get rid of these prisons. If you look at the prison populations, in the general population, about 12% are black people or people of color. But in the prison population, that figure is about 30%. The chances of a black youth winding up in prison is something like 5 times higher than a white youth in America. So the entire Black Lives Movement, the movement that happened and the killing of Floyd and people like that, a lot of that was covered in the press. And I won't go too much into that. I think the opium wars were mentioned and how Europe traded with China. The wars currently in Afghanistan, Pakistan, Mexico, those are all wars supposedly, but we know what has happened to those regions. Here in South Africa, if you look at alcohol and alcohol fetal syndrome, you have lovely wine here in Cape Town, lovely winelands, but who owns that land? Where's the money being made? If you start to understand all of that, you'll see how money, rich people, and people who, and where that, the money is going to. In South Africa, we had an added complication. We had grand apartheid and the creation of Bantustans, and KwaZulu-Natal and Transkei were sort of holding areas where migrant workers would serve the mines in Johannesburg and in the Free State, the gold mines, and also the industrial areas of the metros. And there was no economies in these poorer areas, and cannabis played quite a role in poorer households in these rural Bantustans. But if you look at how the cannabis industry has grown now, those households, those families, those communities, those farmers are nowhere. CBD oil, the entire marketing of it. So follow the money and see how drugs, how legislation, how trade and industry policy is actually not focusing on where poverty, inequality, oppression, and it actually feeds the existing economic systems, the existing races that actually own and control the economy. That was at a national level where you had the Bantustans and the provinces. In the cities, apartheid cities and the cities were much more controlled. So Cape Town is a city there's huge urban ghettos, extensive shacklands, and fabulously rich Atlantic seaboard. If you wanted to buy a house on the Atlantic seaboard, you have to have dollars. They advertise the prices of those houses in dollars. You can't buy them in rands, simply put. The entire city bowl of Cape Town is not owned by South Africans. It's owned by foreigners. Sex work, drugs, and violent gangs, and the extent to which the ghettos in Cape Town, someone also spoke about the intersection between violence, gangs, and it's so evident here in this city where we're having this conference. So coming back to this and trying to understand policy, at NACOSA we're trying to be putting people first in the work we do. And the first place we started was with our values. So we value others by listening with empathy and responding with care. We recognize and respect the agency, dignity, and strength of communities and people. So the work we do at NACOSA is, and how do we sort of build this into our work? And I'm trying to move towards saying what are the policy implications in the way that we formulating policy. We facilitate networking and collaboration with organizations, movements, donors, government, institutions, and business at local, national, regional, and global levels. So this bringing together of a wide range of people to actually focus on issues, but led by communities of peerhood, that would be the core of making policy. Building networks to consolidate a collective voice and build a collaborative, broad-based community within the public health ecosystem as NACOSA, but you can read within the peerhood ecosystem. and then advocate, learn, and share collectively through consultative forums, local planning and coordination, community-led service monitoring, community dialogues, sharing, learning, and advocacy. So that's what we try to do, and what we hope to achieve is to shift power. We want to shift the dominant organizational culture, build on collectiveness, and ignite strategic partnerships with organizations and the constituency of PWD in the way that some of my colleagues, Yolan, are running programs that we're running at NACOSA. We want to transform this ugly competitiveness into compassion and reflecting this in our engagement and communication with others. So for us then, decriminalization is a key policy that we need to drive and would be wanting to support as NACOSA. And how would we do that? We think strengthening the community of PWD to be involved in policy and legislation process, and so building a network of organizations and supporting that network is something that we'll be very interested in doing. Recognizing that poorer drug users have the complication of poverty and in extreme instances, homelessness. It's been written about that, remove homelessness and you'll deal with drug use for people that live on the streets. So this intersection between homelessness and drug use is very clear and stark. And so having an effort and the way in which all of this comes together is important for us. How will we do this? And I'll leave you with sort of 4 concepts. So using concepts like centering the margins, asks whether we're making the perspectives of people belonging to the PWD community the central axis around which discourse evolves. It does require us to ask the question repeatedly as to how we would center the perspectives and understandings of the PWD community in policy making. Digging beneath the surface of information to develop deeper understandings of concepts, relationships, and personal biases. In developing our policies, are we paying sufficient attention to what is actually going on in PWD communities and individuals' lives? Ways of knowing that result from critical analysis of PWD personal experiences, infusing storytelling and increasing qualitative reporting in policy development will be helpful in bringing out the lived experiences of PWD. The policymaking process relies heavily on quantitative data, as you heard from the presentations. Things like significant change methodology relies on the story being told using the perspective of the person and organization in developing policy. It centers the experiences of the individuals and organizations in the policy framework. So what I'm asking for is a different process and a mechanism, different kinds of research that result in policy making. Stigma and our approach to stigma. Recognize the extent to which stigma towards people who use drugs impacts on the policy process. Drug use is stigmatized as a weakness amongst people and not as an addiction that a person is struggling with. Do we adequately recognize the stigma associated with drug use and how this impacts on our policies? The approach of harm reduction recognizes this. And so we group harm reduction in our stable of human rights work. Ordinariness, that the nature and existence of PWD amongst, for example, homeless people is integral and normal rather than aberrational. Recognizing and working with the concept that we do not live in a normal society is central to improving our policies. The levels of poverty, inequality, and violence in our society is not normal. Using drugs like alcohol, nicotine, and opioids is not normal when used in a manner that it disrupts one's functioning as an individual and contribution to society. We have become numbed by the poverty all around us and accept it as normal. Let us not accept that poor people who use alcohol and other drugs is normal. Thank you.
Thank you so much. All right, we started a bit late, so we will have about 10 minutes of any questions from the audience to our speakers. Okay, go for it. Is someone got a roving mic or something? Or can you speak? Oh, perfectly, okay.
My question is for Mr. Rengaswamy. Pleased to meet you, sir. My name is Motala, Fields of Green for All. While I understand that you didn't write the World Drug Report, so you're not responsible for its wording, but I just wanted to ask you, you quoted from the World Drug Report that cannabis is reported by a large share of countries as the drug of most concern. What is that concern?
Let's take 2 more questions, if we have them. Oh, right here on this side. Please, if you could.
All right. Good afternoon. My name is Mohamed, and I think I'm happy we had the last presentation. The question I wanted to ask the panel, especially when we talked about power, is that how our policies are made or what informs. There's a lot of work with regards to just South Africa and the global opium politics. I mean, for South Africa, it extends as far back as the 1800s. And so much so that there's colleagues who've actually looked at the influence between Mozambique and South Africa at the time. Interestingly, for Mozambique, Portugal, the driver for opium was political and commercial aims. Yet South Africa, for our regulation, was a lot of pressure on international authorities. And so I asked myself here, and to everybody here, is to think, how do we check ourselves that the global north, and because what you said yesterday, that we could possibly have recolonization through our policies. So how do we check ourselves within this policy space in that we don't repeat it and that we're aware of when sometimes policy can come from a humanistic realm, how do we check that there's no political or commercial aims that are masqueraded as we are being humanistic and putting people first?
Great. Well, let's take those 2 because they're pretty big. Gunnar, maybe you start first, and I think the mics are on. Yep, they are.
Thank you for addressing this. As you correctly said, I'm not the author of the report, but the question is well heard. The primary concern is actually increasing, cannabis use. I think that's how the World Drug Report is reporting. That's one. And the other thing, like I said, since we have a significant younger population, the young people using, cannabis also is increasing. That's what I think the report is referring to.
No, sorry, I'm going to interrupt you, yeah, because we are so tight on time, and I've tried to keep it together today. Maria, would you mind responding to Daniela's question first, and then Charity and Mohamed as well? Thank you.
All right, thank you. So what I would say is that, first of all, as these policies are being proposed, or these agenda is being proposed to us, as governments or as policymakers, what we need to first of all do is to demystify what exactly is this policy seeking to address. We need to run it through a number of checks. Because what you see most of the time is that our governments move into some of these discussions, they quickly sign these things because they want to sort of like be able to get some kind of international support on some of these things. And that is why we need to really do a lot of auditing of some of these things. Juxtapose them to what is happening, the realities. Are they really things that will really support and benefit the people? And that is where I say that we need to really do a lot of auditing, especially as persons placed in certain strategic places, for instance, civil society. If we have the opportunity, we need to push our governments to really do a lot of analysis and demystifying what is actually behind these policies that are being pushed to us to adopt. And by doing so, I believe that we should be able to decipher what exactly is this going to benefit us as South Africa or Ghana or Zimbabwe, and not what we are doing and dancing to the music of somebody who wants a certain direction move regarding, in terms of that particular policy. We've seen, for instance, let's take an example. At the CND level, we've had conversations and countries pushing for, let's say, ketamine, tramadol to be scheduled. I have always said that our government really looking at the impact in terms of that strategy that is being pushed by some countries to have this schedule? What will be the impact on the lives of these people that you are serving as a politician? And so if this is something that is not beneficial to our people, of course, we know some of our governments really will always want to look good and also to be able to go back to these people and get aids and things like that. But will this really benefit our people? We need to really break down this and see if it's beneficial to our people, and if it's not, we should be honest enough to say that no, we cannot. And the institutions themselves that are also supporting government and politicians to make sure that this runs successfully, we need to be honest to say that this is not going to help us. For instance, Ministry of Health can say that this is not going to help the health sector. So why do we have to go that direction? And we can say no to that. And I believe that the people that we are serving will support such an agenda in terms of such circumstances.
Thank you, Maria. So for me, globalization was a blessing and a curse. And the fact that we live in an international community has just made it very difficult to be a lone soldier in a global economy. And so it's exactly what Maria says. We are influenced by a government or a country that's going to say, I'm going to fund this. And so they dictate exactly what happens in our countries. And I think as civil society, we need to, as Maria said, have an audit where we are involved in policy discussions and decision making, because a lot of our policies do not go anywhere because there is no civil society consultation. We see that with the cannabis bill. There was no research done into it, and that's why we're sitting with the challenge where government is like, okay, where do we go from here? And so there isn't enough research done in regards to policy. There isn't enough civil society involvement in policy discussions. And I think it's great that departments like social development make an effort to adopt, so to speak, strategic partners. So for example, SANPUT is the Department of Social Development strategic partner, and they always ensure that any discussions relating to drug use, SANPUT is always called to the table. And so that has influenced the National Drug Master Plan, including harm reduction explicitly, and efforts by Department of Social Development and Department of Health to actually action points or take steps to ensure that there are harm reduction strategies that will be implemented. And so I think it's really, really important that we need to hold governments accountable on making sure that any policies that are passed or that are in discussion should involve civil society organizations and people that are actually affected to ensure that we're actually addressing the issue correctly.
Hi, thank you. So yeah, the question was around power, and you asked the question, how do we check ourselves? And the picture I was trying to paint was, look, if we follow the money and we see who's benefiting from the kinds of legislation, from the kind of policy that we're having, that leads us to look at where, where it's coming from and who's making that policy. Understanding the history and the patterns of that, and how it's playing out currently, right from cannabis, what happened, right through to COVID. So the cost of drugs, even now, palliative care and the cost and the access of that to poorer countries and poorer communities, and who has access. So even in the legislative process, voluntary euthanasia, for example, in European countries and richer countries, you can go for that now, and there are places. So I think there's also work that we need to do on ourselves and in our communities. Because if you start to talk about things like that, voluntary euthanasia, the whole harm reduction, that work, and the fact that our governments have backward policies. So I don't know if you know Neil deGrasse Tyson. Neil deGrasse Tyson said, if your governments make crap policies, You need to educate the people.
Yep.
Because the governments are just representatives of the people. They tell you what the people want and what the people are saying. So if the people are saying that, if the governments are saying it, that's where the people are at, and that's where the work needs to happen to change the policies. Thank you.
Thank you so much. We can take one last question. Does anybody have? The lady over here. Yes?
Thanks for the discussion, and I just found it very interesting. Our discussion is centered around the users, the drug users, the affected, and then you're saying it's people's first. But this is understood, but my question is around what is our approach around the supply in terms of the policy development and policy direction. The second one is around the homelessness. Remove homelessness and we will deal with drug use. The question is how.
So, Gunnar, I'll have you take the first question, if that's okay. Oh, they're both on that side. You just.
Okay, thank you. Thank you very much. When it comes to the supply question, actually the UN General Assembly's the special session which had the outcome document, which clearly says that it has to be a balanced approach. It really looks at supply reduction, demand reduction, and harm reduction. But when it comes to actual supply side, actually there is a lot of program that is happening. But is it enough to the extent to prevent the drugs coming in? When there is a market for something, there will be profit, and people are going to buy it. So these are organized cartels. So there is so much more effort needs to be done with regard to a balanced approach when it comes to supply reduction. It is not that easy. Like I said in my presentation, that the new psychoactive substances are produced in clandestine labs, right? It requires a small room with some technology. It cannot be detected, and it is coming. New drugs are coming into the market. It may not be that easy for law enforcement officials to really bust these emerging manufacturing hubs, but still it is happening. So I think lots more, when it comes to the whole issue of whether be it supply reduction, demand reduction, or harm reduction, when it is really to drugs, there is much more needs to be done, is what I would think. Thank you.
I'm actually going to stop us now, but could I ask you two to talk later about the second question, if you'd like? And same with the woman at the back with the glasses who asked the first question. If you can grab Gunnar later, that'd be great. I'm going to have to wrap up now so y'all can have some lunch before the session at 2 o'clock. And so today, I just want to say thank you again to our amazing speakers, because they really took us on a journey looking at power and politics and policy and privilege. And I think some of the highlights that came out that for me were the fact that we haven't looked at and we haven't done at a national, provincial level, or even at a district level, a cost-benefit analysis between how much it costs to continue the war on drugs and our current war strategy on drugs, and how much money we could actually move to our communities, health, social welfare, and justice programs. So that's something for us to consider when we're starting to look at our budgets as we move forward. Is it actually worth what we're spending in terms of the war on drugs? We talked a bit about data. I mean, at the end of the day, if we don't have good population size estimates, how on earth could we budget for programming, and how can we scale up? It's inconceivable to me, the fact that most countries still don't have accurate data. I sit on the Global Fund Technical Review Panel, so I read all the country applications, and some of them will say, give me population size estimates from 2015. I send it back because that's just not appropriate. So that's something we also have to consider. The correct data will give us correct budgets. Around the power and the amount of power that we've now given over to law enforcement, for example. And here in South Africa, when apartheid ended, the apartheid police became the war on drugs police. And then we militarized them even more, and we invested even more money into them. And then we now have to consider whether a militarized police force fighting our own people, so we are fighting ourselves, we are giving them money to fight us. Is that appropriate or not? So this is something for us to also consider how we can approach that as we move forward. And that's why we've got this campaign, Divest, Invest, because we really want people to look critically at budgets and look at where money is being spent and how it could be spent in better ways. Because we have to also move away from the over-reliance on international funding. Because our militarized police force didn't just happen. It came because the United States, Russia, and China, for example, provide so much technical assistance to law enforcement in South Africa. So we're taking their money and we're doing this and we're going with what their priorities and their strategies. And then finally, Mohamed also talked about policy and the drivers of current policies, and the fact that we really do need to look at where the money is and where it's going. And I think a really good example of this is what happened in 1953 in Iran when Mohammad Mossadegh was the head of state. And the Anglo-Persian Oil Company, which was a British company, was basically running the country. And so he came into power and he decided to nationalize the oil company because then he could pay for infrastructure, education, and health for the entire country. And the United States and the UK objected to this, and so they had an operation, all the documents are now open, where they actually held a coup and got rid of him. And so the problems that we see today in Iran came from that, right? So when people talk about Iran today and they're like, oh my God, it's a dictatorship and all of this, well, actually there's a root cause for it. And today in the UK, British Petroleum, which used to be called Anglo-Persian Oil Company, but they needed a rebrand because they were so awful, BP still does not pay taxes in the UK. So the national health system is crumbling, but they don't pay taxes. And so we have to also consider all of those investments that are being made in our countries right now. For example, in Mexico, because they have decriminalized cannabis, the number of corporations from the United States that are going into Mexico right now to take over the cannabis industry is obscene. And Colombia is also on the verge of decriminalizing cannabis and potentially cocaine. We'll hear in a matter of months. And so guess what? All those American cannabis corporations are trying to go in. And that means that instead of an example like Oregon, which is a state in the US, where they decriminalized all drugs for personal use, and then they taxed cannabis, and all that tax money from cannabis funds all the harm reduction and other social and health programs in the entire state. Right? So we also have to be forward-thinking about the fact that we will eventually have decriminalization in South Africa and hopefully the rest of the region. And we have to be forward-thinking about the fact that we need to be in control and charge of those companies and not allow others to take over. So I'll leave you with that, but I thank you all for being here today, and I hope that you get to talk to our amazing speakers during the lunch break as well. Thank you very much.